In my last video series on autism and diet, I talked about the benefits of broccoli sprouts, but the most commonly studied nutritional and dietary interventions for autism and diet involve variations of gluten-free and casein-free diets. Where did that even come from? In the 80s, a team of respected Norwegian researchers reported a peculiar finding. They were comparing the urine of autistic children to the urine of normal children in hope of teasing out any differences that could lead to hints as to what the cause is. This is a urine profile, which shows spikes for each of the various components. This is what normal urine comes out like, with the peptides region pretty quiet. Peptides are like small pieces of proteins, and normally we shouldn't be peeing out much protein. But this is the urine profile from a child with autism, with all sorts of peptide spikes. Here's another one. This raised the question, can the pathophysiology, the dysfunction of autism, be explained by the nature of these discovered urine peptides? First, they had to answer, where do the peptides come from? They didn't know. But there was a clue. Most of the parents of autistic kids reported that they got worse when they were exposed to cow's milk. Well, there are these two proteins, gluten, a protein in wheat, and casein, a protein in milk, that break down not only into peptides, but exorphins. Exorphins are opioid peptides derived from food proteins, called exorphins because of their exogenous origin, meaning from outside of the body, and morphine-like activity, as opposed to endorphins, which are morphine-like compounds we produce inside our bodies. So maybe some of these food peptides represent like a new class of hormones. So is that what the kids were peeing out? Apparently so, as some of those peptides had opioid activity. OK, so maybe they were onto something. There are two types of opioids that have been found in milk. One is the casomorphins. In view of their morphine-like activity and their origin, their breakdown products, fragments of the milk protein casein. What's the other one? The other opioid is the actual opiate morphine. There appears to be actual morphine in milk. This can't just be a coincidence. It's hard to believe that these or other types of opioids found in the milk are devoid of physiological or nutritional significance. And think about it. It makes total sense. Morphine and the opioid peptides may have an important role in the mother-infant bond. We want infants to be addicted to their own mother's milk. OK, but what about the milk of another species? Human breast milk is markedly different from that of other species in that it has the lowest casein content. And human casein is a markedly different protein in terms of its sequence of amino acid building blocks. Human milk has 15 times less casein than bovine milk, and differs sequence-wise by about half, and so breaks down into peptides differently. 21 bioactive peptides have been recovered from cow casein, including multiple casomorphins, compared to only 5 active peptides identified in human milk and only 1 casomorphin. And the casomorphins from bovine casein are more potent. This is a graph of opioid activity where lower means more potent. Here's the potency of straight morphine. And here's bovine casomorphin, significantly more potent than the weak opioid peptide from gluten, which is more comparable to the human casomorphin from breast milk. And indeed, when you expose human nerve tissue to bovine casomorphin, it acts more like morphine than the casomorphin from human breast milk, in terms of epigenetic changes in gene expression, not only providing a molecular rationale for recommending breastfeeding over cow's milk formula, but also providing a possible explanation why casein-free diets have been reported to mitigate some of the symptoms of autism. What's good for the goose may be good for the gander, but what's good for the cow could be harmful to the human. One of the main sources of protein fragments with opiate-like activity in the diets of autism patients are dairy products. The main dairy protein casein breaks down into casomorphins, which have been considered to be factors involved in the cause and exacerbation of symptoms in food allergy and eczema, diabetes, schizophrenia, postpartum psychosis, crib death, and autism. According to this opioid excess idea, the development of autism includes a genetic predisposition, early exposure to some kind of environmental stressors that affect the gut, which may cause more of these casomorphins to leak into the blood, and then the brain, where they may play a role in the development of autism. But you don't know until you put it to the test. First of all, do these bovine casomorphins form in the human digestive tract when we drink milk? Researchers decided to stick tubes down into people's intestines to find out, and indeed, considerable amounts of casomorphin were found. OK, but do they get absorbed into the bloodstream? Yes, apparently so, but this study was on infants who naturally have leakier guts. Do fully intact casein protein fragments make it into the bloodstream after infancy? Yes, even into adulthood, elevating levels in the blood for at least 8 hours after consumption. And those with autism may have an especially leaky gut, at significantly higher risk for abnormally high intestinal permeability, which may explain why the vast majority of autistic children may have antibodies in their blood to wheat and dairy proteins, compared to a small minority of normal children. And based on allergy studies, even if an infant is strictly breastfed, they may still be exposed to bits of bovine milk proteins if the mother drinks milk, as the bovine protein fragments can get into her blood, then her breast, then into her baby's body. But does it get into the baby's brain? Yeah, those with autism are more likely to suffer from leaky gut, but the so-called opioid excess theory depends on casomorphins not only getting into the bloodstream, but up into the central nervous system, the brain. And there's something called a blood-brain barrier that helps cordon off the brain. But when you examine the brain tissues of those with autism, their blood-brain barrier seems leakier too. And indeed, evidence for the presence of casomorphins within the brains of infants has since been confirmed, which again just makes sense. That's the whole presumed point of casomorphin opioids, to affect the brains of babies so they crave the milk, cry out for the milk, strengthening the mother-infant bond, the cow-calf bond. That's what's supposed to happen. It's normal, natural. OK, then why are casomorphins associated with disease? Well, this is normal and natural. This, not so much. Human infants with evidence of higher baseline levels of bovine casomorphins in their blood seem more likely to be suffering from psychomotor delay, which is a measure of muscle, language, and mental function development. But the reverse was found for human infant exposure to human casomorphins, meaning human casomorphins appear to be beneficial in humans. See, just like bovine casomorphin levels in the baby's blood appear to rise after feeding cow's milk formula, human casomorphin levels rise in the baby after breastfeeding, and that's what's supposed to happen. The greatest baseline human casomorphins was revealed in breastfed infants with normal psychomotor development and muscle tone. In contrast, elevated baseline bovine casomorphins found in cow's milk formula-fed infants was associated with delayed psychomotor development and stiffened, more rigid muscle tone. The explanation of the opposite effects of human versus bovine casomorphins on infant development probably has to do with species specificity. Cow's milk is good for calves. Breast milk is good for babies. Indeed, the structure of bovine and human casein is dramatically different, and the bovine and human casomorphins themselves are different molecules, differing by 2 amino acids, which results in greatly different potencies. Compared to human casomorphin, bovine casomorphin is highly potent and more similar to morphine in its effects. 2 amino acid difference doesn't seem like a lot, but casomorphins are only 7 amino acids long. This 30% or so difference likely defines the difference in their biological properties. Both human and bovine casomorphins interact with opioid and serotonin receptors, which are known to be of great importance for brain maturation. But cow casomorphin binds tighter to these receptors, and so has more of an effect. This can therefore help explain not only why breast is best, but the psychomotor delay linked with higher bovine casomorphin levels in the blood supports this concept that cow casomorphins may play a role in a disease such as autism. This is why bovine casomorphins have been called the devil in the milk. But are they formed from all cow's milk? What about so-called A2 milk? The A2 Milk Corporation points out that there are different variants of casein. Some cows produce milk with a kind of casein dubbed A1, and other cows produce milk with A2 casein, which differs from A1 casein by a single amino acid, but strategically located such that A1 casein breaks down into casomorphin, which acts like morphine and is implicated in digestive, immune, and brain development changes, but supposedly A2 milk does not. Put A1 milk in a test tube with some digestive enzymes, and the A1 casein breaks down into casomorphin. But because of that amino acid difference, the A2 casein breaks down at a different spot, and so no casomorphin is formed. But this was using digestive enzymes from pigs, or cows, which are just cheaper and easier to buy for laboratory experiments. But human digestive juices are different, and so what happens in a pig stomach or cow stomachs may not necessarily be what happens in the human digestive tract. But the A1 versus A2 breakdown experiment had never been performed with human enzymes before. Until now. Human stomach and intestinal juices were collected, and the devil was in both. The opioid casomorphin was produced from both A1 and A2 milk, so A2 milk may be better for this babe, but not necessarily for this one. The so-called opioid excess theory of autism is that when certain wheat and dairy proteins are ingested, morphine-like protein fragments are created that then leak into the bloodstream, cross into the brain, and cause neurological damage that can manifest as autism. The whole theory started with the apparent discovery of these opioid peptides in the urine of children with autism, but missing from the urine of children who develop normally. But a decade later, a more specific test failed to find urinary opioid peptides in children with autism. The spectral analysis of urine from autistic children, the pink line here, is practically identical with that of those without autism, and so the whole theory was called into question, until a more sensitive test was developed. Elevated concentrations of circulating casomorphins, the exogenous opioid peptides from bovine milk casein, may contribute to the development of autism in children. But because several studies failed to detect casomorphins in autistic children, this was called into question. Here, however, they demonstrate that autistic children do indeed have evidence of significantly higher levels of urine bovine casomorphins than normal children. Furthermore, the severity of autistic symptoms correlated with casomorphin concentrations. The more casomorphins they had flowing through their body, the worse their autism symptoms tended to be. Because casomorphins interact with opioid and serotonin receptors, the known modulators of synaptogenesis, the creation of nerve-to-nerve connections within the brain, maybe chronic exposure to elevated levels of bovine casomorphins may impair early child development, setting the stage for autistic disorders. But you don't know until you put it to the test. If increasing exposure to casomorphin opioids from cow's milk is correlated with increasing severity of autism symptoms, why not just try giving kids opioid-blocking drugs? That's such the medical mentality. Instead, why not try to treat the cause with a dietary intervention, not only to see if, indeed, it even is a cause, but if it is, to see if we can actually help these children. It started with case reports like this, where a 7-year-old girl with autistic behavior is described as benefiting from a gluten-free, casein-free diet. A quite remarkable case in which, over a period of 2 years, the girl changed from being severely withdrawn to a normally communicating child who enjoyed the company of others. And her dramatic improvement seemed to correlate with decreasing urine peptide levels after 1 year, then 2 years. OK, but maybe this one case was just a fluke? Some docs figured it was worth a try and published spectacular results like this, claiming 80% of their autistic children improved after 3 months of a gluten-free, casein-free diet. Even just specifically cutting out the cow's milk protein, the casein, appeared to lead to marked improvement in behavioral symptoms. But none of these studies had a control group. It wasn't until 2002 when the first randomized controlled study of a dietary intervention in autistic syndromes was published. 20 children with autism, half randomized to a gluten and casein-free diet for a year, tested before and after, and those on the diet did better. Did better how? Here's where the resistance to communication and interaction scores of all 20 kids started out in the diet group and the control group. This is the before. If there was no change after a year for any of the kids, the bars would end up looking like this, the same before and after. The gray is the before, the black is the after. But the control group actually ended up like this. So 2 got better. Remember, this is resistance to communication and interaction, so the lower the better. 2 got worse, and the rest were just as bad off as they were when they started. But in the diet group, they all got better. Social isolation scores. Again, the lower the better. In the control group, half got better, half got worse, or stayed the same. In the diet intervention group, they all got better. Overall, in terms of total impairment, half got better, and half got worse in the control group, but in the diet group, they all got better. What does that mean in terms of real-life terms instead of just numbers? All the kids started out sharing the most common autistic trait, lack of relationships with their peers, ignoring other children or not knowing how to interact. Some had abnormal temper tantrums or strange emotional reactions, like laughing when other people cried. Extreme anxiety was noted in some of the children in response to common situations. These unusual emotions were drastically reduced in the diet group, but not in the control group. Inability to take other people's perspective and lack of empathy, also other common autistic traits. Some of the children could suddenly hit or bite others or make negative comments. Progress was made regarding development of empathy in the diet group, but not in the control group. Some children also disliked and rejected physical contact, even from their parents. This was no longer a problem after a year on the diet. While none of the changes were significant in the control group, significant positive changes were registered in the diet group regarding peer relationship, anxiety, empathy, and physical contact. The first randomized controlled trial to put a gluten-free, casein-free diet to the test for children with autism reported significant improvements in attention problems, less aloofness, fewer needs for routines and rituals, and improved response to learning after a year on the diet, whereas there was no significant difference reported before or after in the control group. Same with improvements in social and emotional factors. Significantly fewer problems with relationships to their peers, less anxiety, more empathy, and more acceptance of physical contact. But again, no significant changes reported in the control group. Significantly fewer communication problems too, more facial expressions, better eye contact, more responsive, and fewer things like meaningless word repetition in the diet group, whereas no significant changes in the control group. And in terms of cognitive factors and movement, after a year on the diet, there were significant improvements in the ability to judge dangerous situations and expanded personal interests, and a lower likelihood of being inordinately restless or passive. Now, the problem with this study is that they relied mostly on parental report. They asked parents questions like these before and after the year-long trial to see if they detected any differences. Why is that a problem? I mean, who better knows the day-to-day functioning of children than their parents? Yeah, they could have had some impartial observer come in before and after and make assessments, blind to which group the children were in, but those would just be like snapshots in time. Who better than the parents to know what was going on with their children? The problem is the placebo effect. Here the parents are investing a great deal of time and effort to maintain these strict diets. There's wheat and dairy and so many products. It's a big shift for most families. And so they have this hopeful expectation of an effect. So while the families in the control group did nothing special that year and reported no significant changes before and after, the families in the diet group put all this work in, and so when asked if their kids appeared better, their opinions may have been impacted by their expectations of benefit. In other words, placebo effects may have been at play. Oh, come on, though. Are parents that gullible? Well, the power of suggestion on the part of parents can be very strong in situations affecting their children's behavior. For example, there was this famous study in which all the children were given a drink with artificial sweetener, but half of the parents were told that the drink was sweetened with a boatload of sugar. And the parents who thought their children had received the sugared drink rated their own children's behavior as significantly worse. So in these autism studies, it's possible that parents were unconsciously looking for positive changes in behavior and ignoring or explaining away negative changes. So ideally, what we need are double-blind studies, where kids are given foods made to look and taste the same, but one food has gluten and casein and the other doesn't. The kids don't know which is which, the parents don't know which is which, even the researchers at first don't know which is which until they break the code at the end. In this way, the behaviors recorded after the food challenges couldn't be impacted by preconceived ideas or biases. OK, so why didn't this study do that? With regard to design, the researchers concede, it might be argued that a double-blind study might have been ideal. With all children on the diet, gluten and casein could have been secretly administered, for example, in capsules with wheat flour or powdered milk during specific altering periods. Then parents and caretakers would have been blind to who was still on the diet and who was, unbeknownst to them, actually off the diet, secretly getting gluten and casein. Then we could eliminate the placebo effect, eliminate that expectation bias. So why didn't they do it? The researchers refused to do it because they were so convinced that gluten and casein were harmful that from an ethical standpoint, they just couldn't bring themselves to give these kids gluten or casein. The kids in the diet group seemed to be doing so much better, and they had seen cases in which kids appeared to relapse when those proteins were reintroduced back into their diet, and so they just couldn't bring themselves to slip them any on the sly. I understand that, but if they were really so certain that gluten and casein were bad, then by designing a less-than-ideal study, they were potentially dooming scores of other children by failing to provide the strongest possible evidence. Thankfully, 4 years later, other researchers stepped in and published the first double-blind clinical trial of diet and autism. The first randomized controlled study of a gluten-free, casein-free diet for autism found that parents in the diet group reported their kids did significantly better. But that could just be the placebo effect, where parents attribute changes to the diet, particularly since they're putting so much work into it that they may be biased towards seeing evidence of success that may not actually be there. OK, so what if you don't just rely on parental report? What if you do a blinded study of a gluten and casein-free diet? The parents know what the kids are eating, but you don't just ask the parents how the kids are doing. You have investigators objectively assess all the kids without knowing who was in which group, the diet group or the control group. And they found a significant beneficial effect at 8, 12, and 24 months on core autistic behaviors with a gluten and casein-free diet. And this was one of the largest such studies ever done, starting out with 73 children. But they didn't end up with 73, since about a fifth dropped out, mostly from the diet group. If a family didn't feel their child was making strides on the diet, they may have been more likely to drop out of the study, thereby skewing the analysis towards those in which the diet appeared to work better. And so the remarkable results they got in terms of improved social interaction and fewer ADHD-type symptoms may have ended up exaggerating the effects of the diet, since the kids for which it didn't help may have been gotten kind of disproportionately weeded out. Also, because the parents were very much aware whether they were in the diet group versus the control group, because they were the ones cooking the meals, they may have changed their own behavior towards their children. Like in that famous sugar study, where mothers were lied to and told their children had just received a whopping dose of sugar, even though they hadn't. Not only did the mothers rate their children as significantly more hyperactive, they inadvertently changed their own behavior. They were videotaped, and the mothers who falsely believed their kids just got a load of sugar exercised more control and were more critical. So their expectation of an effect may have actually ended up having an actual effect in changing their children's behavior. So in these autism studies, here the parents are upending their family's diet, hoping, expecting that their child will get better, and maybe unconsciously treating them differently, such that they end up behaving differently when assessed later by the blinded investigators. That's why we need double-blind studies, where no one knows who's in the diet group, who's in the control group, not the parents, not the kids. So why didn't the researchers do it? Why didn't they secretly sneak some gluten or casein into their diets to see if they got worse again? Same excuse as before. It wouldn't be ethical. But that's pre-deciding the outcome. It's like circular logic. We can't test to see if it really works because it may really work, but we can't test that. Finally, however, researchers at the University of Florida broke through the impasse by performing a double-blind study. Now, this is not an easy thing to do. You have to provide all meals and snacks, so that the families remain clueless as to whether they were randomized into the gluten and casein-free diet group or were actually in the control group getting the same foods, but with gluten and casein slipped in. Then, after 6 weeks, they switched the food, so the gluten-free, casein-free group started getting wheat and dairy, and the wheat and dairy control group were covertly switched to gluten and casein-free. Before they broke the codes to see who was in which group, the parents were asked as to whether they thought their child was on the special diet during the first or second 6 weeks, and 5 got it right, 2 had no idea, and 6 got it wrong. In other words, no better than a flip of a coin chance. About half pretty much thought their kids got better on the casein and gluten. So no statistically significant findings, though several parents did report an improvement in their children, claiming marked improvements in language, decreased hyperactivity, decreased tantrums, so much so that a bunch of the parents decided to keep the children on the diet, even though the researchers just told them that it didn't work. Look, you don't want to miss anything, though. Some of the parents claimed significant improvement. So what the researchers did was go back and examine the videotapes they made of the kids before and after, and showed them to blinded examiners. Did their language really get better? Apparently not. The videotape showed no improvement, so again did not support the efficacy of a gluten-free, casein-free diet for improving some of the core symptoms of autism, or at least within 6 weeks' time. The non-double-blind studies that showed an effect had kids on the diet for a year or two. And so the failure to find an effect in the double-blind study should not necessarily be interpreted to mean that diet doesn't work, given the relatively shorter duration of dietary intervention. The same issue cropped up years later in a 2014 study in Texas. Simple study design, put everyone on a gluten-free, casein-free diet, and then randomize parents to get baggies each week filled with either gluten-free, casein-free brown rice flour, thereby sticking to the diet, or an identical-looking powder with gluten and milk mixed in. So no one knew until the end who really remained gluten and casein-free, and no meaningful changes were found in either diet group. OK, but this study only lasted 4 weeks, and diet proponents suggest it may take months off gluten and casein to properly assess a response. The problem is there hadn't been any double-blind studies that lasted that long until now. When you read in alternative medicine journals that there's a great deal of evidence that foods containing casein or gluten contribute significantly to autism and should be eliminated from the diet, almost always leading to symptomatic improvement, they're presumably talking about the published anecdotes and case series that claim wild success, but had no control group, though there were 2 year-long controlled trials that also showed remarkable benefits, but couldn't discount placebo effects. The double-blind studies that did control for placebo effects failed to find benefits, but they only lasted a few weeks. This was to be the study to break the logjam, a months-long, double-blind controlled study. They put 14 kids with autism on a gluten-free, casein-free diet for 4 to 6 weeks, and then, for the next 3 months, challenged them every week with double-blind, placebo-controlled food tests, secretly giving them gluten, or just casein, or both, or neither, every week, month after month. Here's what happened to each of the 14 kids in terms of their social relationships and their language skills throughout each of the challenges, and bottom line, nothing. No apparent impact on behavioral disturbances or autism-related behaviors. So does that mean case closed? Well, proponents of autism diets might regard the 4 to 6 week implementation phase prior to the challenges as too short for the gluten-free, casein-free diet to take full effect. In other words, one could argue this is yet another double-blind study that didn't give the diet long enough time to work. And so maybe the kids were still feeling the effects of gluten and casein they consumed more than a month previously, and so no wonder extra gluten or casein didn't make them even worse. It's possible, I guess, which is why you'll see systematic reviews of the sum total of evidence, like this one published 2017 in the Journal of the American Academy of Pediatrics, concluding that although some studies showed benefits, the data are inadequate to make conclusions either way. In other words, the SOE, the strength of evidence, is considered insufficient to endorse such diets. What's the harm in giving it a try, though? Well, given the effort, time, and money that a gluten-free, casein-free diet requires, knowing whether it actually works would kind of be a good thing to know. I mean, there are downsides. Being on a special diet can have unintended negative social consequences when children are not able to participate conventionally in birthday celebrations and class treats, or eat in restaurants or other people's homes. Autism can be isolating enough as it is. The overall evidence for the effectiveness of these diets is weak, and thus these diets cannot be generally recommended as a treatment, yet parents continue to give it a try, figuring, look, the drugs don't work in terms of helping the core symptoms, so why not just give it a try and leave no stone unturned? I can understand that. However, there are the potential downsides, like further stigmatization, diversion of resources away from other treatments, and, they suggest, a concern about nutritional deficiency. What they're worried about is bone health. Those with autism are at elevated risk for bone fractures. Now, lower bone mineral density in individuals with autism may be due to a variety of factors: lack of vitamin D, chronic use of medications that can weaken bones, lack of weight-bearing exercise, but maybe dietary restrictions play a role. Do children with autism on gluten-free, casein-free diets have lower calcium intake? Yes. In fact, 9 times the odds of failing to meet recommended calcium intakes. Does this translate out to reduced bone mass? Maybe so, as those on casein-free diets appear to have less bone development. Now, there's controversy over whether dairy products are the best source of calcium, but that is where most kids are getting their calcium, and so if you remove dairy, you have to replace it with other calcium-rich foods. As the study they cited points out, there's lots of non-dairy sources of calcium, but they only provide calcium if you actually eat them. We've known about painful aphthous ulcers, canker sores, for thousands of years, the most common lesion of the lining of our mouths, named perhaps by Hippocrates himself. Well, what did he prescribe for it? Well, he was a big fan of honey for healing a bunch of sore body parts, though beat to the punch by a few millennia by the ancient Egyptians on that score, also known by the ancient Chinese, perhaps the oldest wound dressing known to humankind. Well, how about a few thousand-year update? Evidently, honey has been successfully used as a treatment of a number of types of wounds, including chronic ulcers. The evidence is apparently strongest for burns. Yeah, but OK compared to what? Compared to a boiled potato peel? I'm not making that up. Apparently, honey works about twice as good as boiled potato peel dressings, perhaps because of an antibacterial effect, whereas the potato peels only seem to kind of cover things up, like slapping on cadaver skin. Ew, maybe I'll stick to the potatoes. But what else are you going to do in a resource-poor country? Here, we have antibiotics to fight infection, so quality of healing is often more defined as the aesthetic look of the resulting scar. So plastic surgery patients had half of their surgical scar covered with conventional dressings, and the other half of the same scar covered in a honey dressing. And the halves of the scars covered in honey healed about a third narrower than those covered conventionally, suggesting an improvement in the healing process. OK, but what about canker sores? Here they report 19 cases. Started out with severe pain, but evidently one day after rubbing honey on the sore, the pain was reduced drastically. In fact, gone in 92% of patients, and in most cases the ulcer was gone completely by day 3 or 4. OK, but there was no control group. Maybe they would have gotten better anyway. Maybe there was a placebo effect. Yeah, modern medicine has neglected honey as a therapeutic agent because the science was poor, essentially a series of published anecdotes. But look, one could argue that there's never been any significant side effects associated with a topical application of honey, so what's to lose? I sympathize with that logic, but would really like to see it put to the test. But there hasn't been any good studies until this one, a randomized controlled trial. Honey tested head-to-head against a steroid gel against canker sores. There's all sorts of things doctors can prescribe for canker sores: topical agents like steroids and antibiotics, systemic medications, even laser therapy. But look, why not seek out the least toxic agent first? May not be the most profitable, but why not start with the safest? So they randomized folks with canker sores into one of 3 groups, where they applied, with a Q-tip 3 times a day after meals, either an over-the-counter soothing pain-relieving paste, or a prescription steroid cream, or just plain commercial honey directly onto the canker sore. Here's what happened. Here are the pain scores. On the over-the-counter stuff, the pain was cut in half by day 4 and gone by day 8. On the prescription steroids, half by just 2 days and gone by 4. What about the honey group? Remember that series of cases that claimed total pain relief in 1 day? Well, it was put to the test, and total pain relief within 1 day. That's crazy. Pain for a week, or just pain for a day. And honey's like 500 times cheaper. What about ulcer size? Mostly gone by 8 days, 7 days, or 3 days, and cut in half in just 1 day as opposed to 3 or 4 days. Here's a before and after. Day 1, massive canker sore, but dab a little honey on 3 times a day, and day 1, 2, and gone day 3. So a significant acceleration of healing and resolution of pain, all without systemic side effects, or local side effects for that matter, whereas the topical antibiotics that are sometimes used can have a variety of side effects. And the nice thing about honey is that it doesn't lead to the development of antibiotic resistance. Now, this was a single blind study, meaning the person evaluating the lesions didn't know which group someone was in, but the patient surely knew, as honey would have had a very different taste and texture. And evidently the Prophet Muhammad was a big fan of honey, and this study was done in Saudi Arabia, and so it's possible there was some bias, but given the extraordinary results, one might want to give it a try. Now, the benefits of honey may be due in part to the phytonutrients from the flowers the bee is making the honey from, so why not try the flowers directly? A chamomile extract appeared to cut pain in half within 10 minutes of application, but they didn't follow them out in terms of healing. But a 2% lavender oil in glycerin solution, 2 drops 3 times a day, also had an immediate effect on pain, and, more importantly, seemed to accelerate healing, wiping out the ulcers by day 4, with pain diminishing in a day or two compared to over a week in the placebo group. However you choose to treat your canker sores, if you keep getting them, you should see a medical professional to make sure it's not some sign of an underlying disease. There are a number of conditions that can manifest with chronic canker sore-type lesions, like inflammatory bowel diseases or acute necrotizing ulcerative gingivitis. I think I'd rather have something like sweet syndrome, or even better, magic syndrome. Who wouldn't want to have magic syndrome? Anyone, I guess, who doesn't want genital ulcers. I think I'll stay a muggle. Eczema, also known as atopic dermatitis, is a chronic inflammatory skin disease. In fact, the leading cause of healthy years of life lost due to common skin diseases, because it's just so common, affecting about 1/5 of us. And it's not just an itchy rash. It's associated with other diseases too. Yes, it can be itchy, exhausting, embarrassing, but in kids may increase risk for ADHD, though that may just be from the sleep deprivation, and in adults may increase the risk of major depression. And it's on the rise. There are drugs for it, of course. There are always drugs. Steroids are the first-line therapy. But then there are immunosuppressants as well, with more in the drug pipeline. The medical profession is desperate when they're forced to go back to the basics and start applying leeches to people. Previously, I talked about the safety and efficacy of other, more natural treatments, but what about diet? Our story begins in 1920, a year doctors were realizing how good this oxygen stuff was, though maybe not as good as injecting people with mercury. But a researcher at Johns Hopkins reported a number of cases in which, by omitting eggs, meat, and milk from the diet, patients' eczema improved. Who's going to profit off of that, though? No wonder it took 58 years before it was put to the test. Figuring eggs and milk were the 2 foods most likely involved in eczema, they excluded them, and chicken and beef, since it may just be chicken and cow proteins more generally, in a randomized, double-blind controlled trial swapping in soy milk instead, and 70% of the patients improved. One person got worse on the no egg, no chicken, no milk, no beef diet, but almost everyone else got better. So the researchers conclude that for many kids, avoiding those foods may induce a clinical improvement. And interestingly, it didn't seem to depend on whether allergy tests showed that they were allergic to milk and eggs. Either way, they tended to get better regardless. You can do randomized double-blind food challenges where you give kids with eczema various foods in opaque capsules, like one with egg powder, one with wheat powder, etc. And egg was found by far to be the most offending food. For example, in this study where they just cut out the eggs, dramatic improvements were documented for both the amount of skin involvement and the severity of the eczema lesions after removing eggs from the diet. But in about 90% of cases, the mom had no idea that eggs were a problem. Why? Because it wasn't like they were eating scrambled eggs or something. Almost all the egg exposure was hidden. They were exposed to hidden egg products and packaged foods, and so they had no idea why their eczema was so bad until this study, where they removed all eggs and egg products from their diets. Eggs are evidently the most frequent cause of food sensitivity in children. Out of hundreds of kids with eczema tested, egg allergy was documented in 2/3 of those with sensitivities. In fact, a child having a blood reaction to egg white proteins appears to be one of the best laboratory tests for predicting future allergic diseases in general. It appears to be the ovomucoid protein within egg white that seems to be causing most of the mischief. About 40% of kids with eczema have some form of food allergy, and the more food allergies they have, the more likely it appears they're going to suffer from eczema and make it worse. Those who react to cow's milk protein are significantly more likely to suffer severe eczema, showing the important role cow's milk proteins may play in the induction and increased severity of eczema in children. Often parents switch from cow's milk to goat's milk in an attempt to improve their children's eczema, but goat's milk should never be given to kids with cow's milk allergy because they often cross-react with one another, which has been confirmed with double-blind, placebo-controlled food challenges. Ass milk, on the other hand, is a different story. Switching kids to donkey milk improved their eczema, and for that matter, horses' milk might as well. The original randomized, double-blind, controlled trial of diet and eczema found that cutting out eggs, chicken, milk, and beef significantly improved eczema in 70% of the kids that completed the study. Subsequent studies found similar results, though in this case, for example, it only seemed to work for a quarter of the kids. But bottom line, out of 13 studies on avoiding milk, eggs, or both, 10 out of 13 studies documented overall clinical improvement. The economic burden of eczema caused by just regular cow's milk formula alone may be hundreds of millions of dollars a year, though eggs appear to be worse in terms of predicting persistence and severity of the disease. Sensitization to egg white and cow's milk can occur even in breastfed infants, though, and so presumably the source of the exposure is the passage of egg and cow proteins through the mother's milk, but you don't know until you put it to the test. New mothers were randomized to cut out eggs, cow's milk, and fish from their diet during the first 3 months of breastfeeding after giving birth, or to continue their regular diet. And indeed, the infants of mothers who cut out the eggs, milk, and fish were significantly less likely to have eczema by age 6 months, though after that age the increased rates of eczema in the no eggs, milk, or fish group was no longer statistically significant. Follow those same kids out to 4 years, though, and those whose moms cut out the eggs, milk, and dairy for just 3 months while breastfeeding had significantly lower eczema rates even years later. Consuming that hypoallergenic diet during breastfeeding cut childhood eczema rates in half. Eating more plant foods may also help. The majority of fruit and vegetable studies suggest that higher consumption by mothers during pregnancy and children in early life results in reductions in asthma, another allergic-type disease. Maybe it's the phenolic phytonutrients in plants that are helping, supported by evidence that certain vegetarian diets appear to alleviate the severity of skin diseases in adults with eczema. Though if you look at that citation, it was a very strange diet. They found striking benefits in terms of reducing the severity of eczema, and even 2 months after they went off the diet, they were still doing better than when they started. But the diet was just vegetable juice, brown rice, kelp tofu, tahini, and persimmon leaf tea, and severely calorie restricted. And just straight fasting alone can improve eczema, as can a strictly plant-based diet, which is not so surprising given the data on children showing how much better they can do cutting out eggs and dairy. In spite of these data, dermatologists and pediatricians have for many years denied the role of food in eczema, even though as many as 80% of kids may benefit cutting out milk and or eggs, regardless of what the various allergy tests showed. You can't necessarily tell if diet is going to help until you yourself put it to the test in your own body, and that's what parents are doing. They're not waiting for their pediatricians to catch up. 75% of children with eczema-stricken kids have tried some form of dietary exclusion, most commonly cutting out dairy and eggs, though only about 40% of parents who tried it feel that it worked. But hey, why not give it a try? A typical recommendation you see in the medical literature is like, look, if you have a child with some bad eczema and the drugs aren't working, then why don't you try cutting out some foods? But that seems to me backwards. If foods are contributing, why not treat the cause and eliminate the offending foods, and then do the drugs if diet isn't enough? Now, there are some pretty nutty eczema diets out there, like the so-called few foods diet, excluding everything except like lamb, potatoes, Rice Krispies, broccoli, and pears. To my surprise, it was actually put to the test. I told you docs were desperate, but it failed to show a benefit. Basically, if you don't know where to begin, the simplest approach may be to just cut out dairy and eggs and see what happens. That's a controversial recommendation, though. Avoiding fish, beef, eggs, and dairy without medical supervision, that might trigger malnutrition-related pathology. What? I checked out that citation, and it's just another article making an unsupported claim. Now, if you exclude everything, like 99% of your diet is rice milk, well, then obviously that's completely insufficient. But for most parents, the number one thing they add to their child's diet for eczema is vegetables, and the number one thing they cut down on is junk food. And I don't think we have to worry about a junk food deficiency. I've done videos on how coconut oil is safe to put on your hair or on your skin, but you certainly don't want to eat the stuff. You may not even want to be in the same kitchen when it's being cooked with. I don't know where people get the idea it's safe to cook with. It's got one of the lowest smoke points. At typical frying temperatures, it can release a variety of toxic compounds, in fact, even below the smoke point, so you want there to be good ventilation. You also don't want to inject it into your privates. And even standing under a coconut tree is not completely without risk. But what about swishing coconut oil around in your mouth? So-called oil pulling is evidently a time-honored folk remedy that involves swishing oil in your mouth, pulling it back and forth between your teeth for purported oral and systemic health benefits. You put a spoonful of oil in your mouth, swishing for up to 20 minutes. If that's too much, you can go 5 or 10 minutes. Then you spit it out, rinse out your mouth, then brush your teeth. I could see how it might dislodge dental plaque or something and have oral health benefits, but what's this about systemic effects? Not only is it supposedly absolutely harmless, but it effectively treats the most varied diseases, in some cases enabling one to avoid drugs and surgery. I was excited to check out this citation until I realized the citation was to oilpulling.com, an ebook, where you can evidently get answers to questions like oil for oil pulling, pulling oil and diseases cured, and the science behind oil pulling therapy, and much more. The moral of the story is, always check your sources. There is one source, cited by oil-pulling proponents, that seems legit, published in the British Dental Journal, but it's just a letter from some guy saying that the literature has reported that oil pulling can effectively treat things like paralysis, meningitis, and chronic diseases like, cancer, AIDS, etc. But absolutely no references are given, so this literature of which he speaks is presumably the fairy tale literature. The bottom line is that there's simply no scientific proof. OK, but what about the oral health claims? If you look at the list of purported benefits, I think oil pulling may adversely impact spell check, they go from blood clots to stopping the growth of malignant tumors, and you look at those citations purported to back such wild statements up, and you won't be surprised at this point to see they have absolutely nothing to do with blood clots, cancer, or any of those other diseases, but instead are references to studies done on dental health. OK, well, let's not spit the baby out with the bathwater. Let's see what they say. The study started out like this. Add oil pulling to some people's regular oral hygiene regimens and stand back and watch gingivitis get better week after week, as the amount of plaque gets less and less. Conclusion: oil pulling has dental benefits. This was with sunflower oil, same thing with coconut oil. Gingivitis, gum inflammation started to get better within a week as the dental plaque goes down. Looks pretty good, right? So, same conclusion. Oil pulling could be an effective addition to one's oral hygiene habits. OK, so what's wrong with these studies? Right, no control group. But why am I always going on and on about needing control groups? I mean, didn't they each act as their own control? Look, we know where they were at baseline, and then look at that. Week after week, bam, 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 down to less than half the plaque, half the gingivitis. What, are we supposed to imagine it's all just one big coincidence that they all just happen to start getting better right after they started the coconut oil? Come on. Let me tell you about the Hawthorne effect. Patients frequently appear to improve merely from the effects of being placed in a clinical trial. Why? Because patients may improve oral hygiene as a result of the special attention or frequent examinations they get. That's the Hawthorne effect, and why it's so important to do controlled trials. Think about it. You know how you may brush really good the morning of your dentist appointment? Well, imagine knowing you're going to be going back to the dentist for an exam every single week to see how your plaque and gingivitis is going. I mean, don't you think you'd brush a little extra well, floss a few more times that month? And that alone could get you these kinds of results. So the only way to tell if the oil pulling had anything to do with it is to have a control group that didn't do the oil pulling, but also knew they would be getting these weekly checkups. But there was never any compilation of controlled studies. What are the potential risks and benefits of the ancient practice of oil pulling, in which oil is swished or pulled between the teeth for like 15 minutes and spit out? There are wild, unsubstantiated claims online, and even in the medical literature. I can believe it's good exercise for your tongue-in-cheek muscles, but healing all organs simultaneously? That statement seems a bit of a tongue-in-cheek exercise right there. Respondents in the British Medical Journal expressed surprise reading that swishing some oil around in the mouth could effectively treat diseases like meningitis, heart-kidney hormone disorders, did I mention cancer, AIDS, etc.? Look, it may help in some way, but for things to enter into evidence-based medicine, we actually need a little something called evidence, without being distracted by illusory effects ascribed by their advocates, especially when another set of respondents shared their experience of a case of severe inflammatory gingivitis that worsened after oil pulling. She stopped, and it got better. They were thinking maybe some of the oil got stuck under her gums. Regardless, maybe people should hold off until we actually have some evidence. Thankfully, there's a Center for Evidence-Based Medicine at Oxford that recently compiled all the controlled trials. Why is it so important there's a control group? Because maybe the reported declines in gingivitis and plaques with oil pulling are just because in the study they had dentists looking over their shoulders with constant checkups, so maybe the study subjects just upped their brushing and flossing game. This is the kind of study we need. No changes before and after in the control group, but a drop in plaque and gingivitis scores in the oil-pulling group. That's more like it. OK, so there does seem to be an effect. But what do those numbers mean? When you test a new drug, it's not enough to show it works better than nothing, better than a sugar pill. What you ideally want to know is, does the new drug work better than the current best drug out there for the same condition? Otherwise, what's the point of a new therapy? That's why drug companies are often forced to use so-called active controls, comparing their drug not just compared to nothing, a placebo, but head-to-head against the leading drug. Here, oil pulling is compared to doing nothing. How about oil pulling compared to chlorhexidine, an antiseptic chemical used in medicated mouthwash, which is considered to be a gold standard in the fight against plaque, cavities, and gingivitis? So here we go, ladies and gentlemen. In one corner we have oil pulling, in the other chlorhexidine, measuring their ability to lower the number of cavity-producing bacteria on people's teeth. And chlorhexidine worked faster, significant drop within just 24 hours, whereas it took a week for the oil pulling to really start working. But by 2 weeks, the oil pulling may end up just as efficacious as the gold standard. In fact, they appeared to work so similarly, skeptical me is critically thinking, wait a second, maybe it's just the physical act of swishing that disrupts the plaque? It would have been cool if they included a third group that just swished with water. And they did. And swishing with water had no effect. Now, it wasn't exactly fair. They had the oil-pulling group swishing for 10 minutes, whereas the other two groups only swished for 1. And so, for all we know, swishing with water for 10 minutes might be as good as the oil. And one could look at this and argue that chlorhexidine actually worked 10 times better, since it got the same effect swishing for 1/10 the time. But chlorhexidine has side effects, potentially serious side effects, like painful desquamation, meaning peeling of the mucous membranes in your mouth, as well as discoloration to the teeth or tongue. So oil has certain benefits over commercially available mouth rinses. It's non-chemical, non-alcoholic, low-cost, and non-staining, yet the effectiveness is unclear. But wait, oil pulling has been shown to significantly drop the number of cavity-causing bacteria on the teeth. Yeah, but does that translate out into actual fewer cavities? That's what we really care about, but it hasn't been studied. They did pair up oil pulling versus chlorhexidine against plaque and gingivitis, and did find they were both able to help to a similar degree, and plaque-induced gingivitis is a reasonable predictor of future dental health, thereby explaining the Oxford's Centre conclusion that oil pulling may indeed have beneficial effects on oral and dental health. A review of the effects of oil pulling concluded that the ancient practice may indeed have beneficial effects on oral and dental health. I've talked about the benefits for dental health, but oral health too. Oil pulling was also tested against oral malodor, also known as halitosis, or simply bad breath. It's believed a quarter of the world's population suffers from it, so they decided to put oil pulling versus chlorhexidine to the test. How do you test for bad breath, though? There's all sorts of really fancy methods: gas chromatography, electronic noses, diamond probes, dark field microscopy, but these are really expensive or not very reliable, so they decided to go with the gold standard. Study subjects were just told to breathe in the researcher's face. And then they wanted to know what the study subjects thought about their own breath, so they asked them to lick their own wrist and sniff it, then give it a score from 0 to extremely foul. And though the subjects themselves thought their licked wrists smelled better after 2 weeks of oil pulling, the researchers disagreed that their breath smelled any better. But after 3 weeks, there was a significant and comparable improvement in breath odor in the oil pulling and chlorhexidine groups. I was excited about this study because they used an actual placebo, colored water, to presumably match the look of chlorhexidine, and swishing for the same duration. Aha! So we can finally answer that nagging question about whether oil pulling cuts down on plaque and gingivitis because of the oil, or just because you're swishing anything in your mouth that long. And the water worked just as well. The same drop swishing with oil, or just swishing with water, suggesting that the plaque is just disrupted by the extended rinsing action. Yes, oil may be 5 or 6 times cheaper than chlorhexidine and safer, but cheaper and safer than just plain water? Yeah, but can water whiten teeth? Numerous websites offer testimonials of oil pulling whitening teeth, but there were no studies published in the medical literature, and so most doctors would just give up there. But these 2 dental professors in Detroit decided to put it to the test. teeth were selected from their stored collection of human-extracted teeth. Sounds a little horror movie-ish. Then they put them in tubes with coconut oil, sesame oil, sunflower oil, along with some fake saliva, and vigorously shake them every day for 2 weeks, and found no evidence to suggest that oil pulling has any effect on teeth whitening. That's like when another internet darling was put to the test, strawberries and baking soda, which was evidently featured on Dr. Oz. Over-the-counter whitening strips worked. A home whitening system works, where the dentist sends you home with custom trays, and in-office tooth whitening works. But the DIY strawberry baking soda mixture failed, as bad as just plain water used as a control. What about dental erosion? In my video on plant-based diets and dental health, I talked about how those eating healthier may have healthier gums, but because they tend to eat more acidic foods like citrus and tomatoes, fruity teas, they may be at more risk for eroding off some of their enamel, which is why we should rinse our mouth with water after eating or drinking anything acidic, anything sour. But what about rinsing with oil every morning? The way our body protects our teeth from erosion is by forming a pellicle over our teeth, a protective layer of mostly proteins from our saliva, but some fat too. So hey, might oil pulling help prevent erosive damage to our tooth surfaces by kind of buttressing this protective layer? You don't know until you put it to the test. Now, they wanted to put the teeth under a microscope afterwards, and that's hard to do when they're still in people's heads, so they put slabs of cattle teeth in their mouth, let them sit there until that protective layer developed, and then oil pulled around the teeth, or not, in the control group, and then took them out and exposed them to acid. If you expose the teeth to acid without putting them in your mouth, within 2 minutes, 120 seconds, significant demineralization takes place. Calcium is dissolved out of the teeth by the acid. But just let those same teeth roll around your mouth for a few minutes, and then expose them to acid, there's less erosion. OK, but then what happens if you put them in your mouth and do some oil pulling? Is there even less erosion? No, there's more. It's as if the oil pulling undermined the protective layer. And that's exactly what they saw under the microscope. Here's what that protective layer looks like before the oil pulling, and then after. They suspect the oil may actually be depleting the protective layer of some of its protection. So far, we learned that oil pulling may be no more effective than swishing with water for plaque and gingivitis, doesn't whiten your teeth, and may even make dental erosion worse. What about oil pulling as a treatment for tooth sensitivity? About a quarter of people have sensitive teeth, like experiencing aching sensations when drinking ice water. So researchers split people up into 3 groups: oil pulling versus a desensitizing toothpaste versus placebo, just rinsing with salt water. And then they blasted people's teeth with cold air. The placebo didn't help much. The before and after sensitivity scores were the same for 9 out of 10 in the placebo group. But the desensitizing toothpaste seemed to help in most of the patients. And so did the oil pulling. OK, so there is some benefit to oil pulling. If you have sensitive teeth, why not give it a try? Unless, of course, there's some downside, some risks associated with oil pulling. Typically, the only concerns you see expressed are for clogging your sink drain or something, but the reason it's warned against in young children is fear of aspiration, that you might accidentally choke on and some oil may go down the wrong pipe into your lungs. And this could potentially happen at any age. But is that just a theoretical concern? No. There are cases of lipoid pneumonia attributed to oil pulling, which is when you get an oily substance stuck down in your lungs. First described in 1925, when it was customary to use mentholated Vaseline in the nostrils of kids, until they died of pneumonia, and on autopsy, areas of their lungs were clogged with oily fluid. Glad we don't use mentholated Vaseline anymore, but we do. That's what Vicks VapoRub is. And if you stick it in your nostrils, you can end up filling up part of your lung with it. That's why you should never put Vaseline in your nose before bedtime. It liquefies at body temperature and creeps down into your lungs as you sleep. And so people need to be aware. I did my part by posting a video about it ages ago, but it's not just Vaseline. Anything oily or greasy can do it. You can give your kid pneumonia with intranasal butter application, evidently a folk remedy for a stuffy nose, which can end you up with a stuffy lung. Same thing with olive oil. Or this poor woman who thought it was a good idea to put baby oil in her nose because her nostrils were dry. Not a good idea. Less common causes include inhaling too much vaporized candle wax because you spend most of your time in a shrine surrounded by burning candles. Lipoid pneumonia isn't nicknamed fire eater's lung for nothing, as performers place themselves at risk for aspirating that tiki torch oil in their act. A thankfully really uncommon cause is self-injection with oil. Why would anyone do that? To increase the size of their genitals, of course, until they accidentally hit a vein and squirt oil into their bloodstream. But this is what concerns me more. Cases like this poor woman, 4 admissions to the hospital with pneumonia within just 6 months. During her 4th admission, her doctors meticulously inquired about every possible cause of her recurrent pneumonia, and she revealed that she had started oil pulling 2 weeks before her first admission. And then when she was discharged from the hospital, she did it even more to try to detoxify from all the drugs they had given her, which led to 3 more hospital admissions. They told her to stop the oil pulling and no more pneumonia. That's one of the reasons the American Dental Association recommends against the practice. In fact, remember that tooth whitening experiment? There's a reason they used extracted teeth instead of just having people do it. They didn't think it would be ethical to conduct a human trial of oil pulling with the knowledge that there was a chance of inducing lipoid pneumonia in study volunteers. In my book, How Not to Die, I suggest we try to center our diets around whole plant foods. But some plants are healthier than others. For example, you can apparently live extended periods eating practically nothing but white potatoes. That would, by definition, be a whole food plant-based diet, but not a very healthy one. All plant foods are not created equal. The more I researched over the years, the more I've come to realize that healthy foods are not necessarily interchangeable. Some foods and food groups have special nutrients not found in abundance elsewhere. For example, sulforaphane, the amazing liver enzyme detox-boosting compound, is derived nearly exclusively from cruciferous vegetables. You could eat tons of other kinds of greens and vegetables on a given day and get no appreciable sulforaphane if you didn't eat something cruciferous. It's the same with flax seeds and the anti-cancer lignan compounds. Flax may average 100 times more lignans than other foods. And mushrooms aren't even plants at all. They belong to an entirely different biological classification and may contain nutrients like ergothioneine, not made anywhere in the plant kingdom. So technically, maybe I should be referring to a whole food plant and fungus-based diet, but that just sounds kind of gross. It seems like every time I come home from the medical library buzzing with some exciting new data, my family rolls their eyes, sighs, and asks, "What can't we eat now?" Or they'll say, "Wait a second, why does everything seem to have parsley in it all of a sudden," or something. They're very tolerant. As the list of foods I try to fit into my daily diet grew, I made a checklist and had it up on a little dry erase board on the fridge, and we'd make a game out of ticking off the boxes. This evolved into my daily dozen, the checklist of all the things I try to fit into my daily routine. By beans, I mean legumes, which also include split peas, chickpeas, and lentils. While eating a bowl of pea soup or dipping carrots into hummus may not seem like eating beans, it certainly counts. We should try to get 3 servings a day. A serving is defined as a quarter of cup of hummus or bean dip, half cup of cooked beans, split peas, lentils, tofu or tempeh, or a full cup of fresh peas or sprouted lentils. Though peanuts are technically legumes, nutritionally I've grouped them in the nuts category, just as I would shunt green beans, snap peas, and string beans into the other vegetables category. A serving of berries is a half cup fresh or frozen, or quarter cup of dried. While biologically speaking, avocados, bananas, and even watermelons are technically berries, I'm using the colloquial term for any small edible fruit, which is why I include kumquats and grapes, and raisins, as well as fruits that are typically thought of as berries, but actually technically aren't, such as blackberries, cherries, mulberries, raspberries, and strawberries. For other fruits, a serving is a medium-sized fruit, a cup of cut-up fruit, or a quarter cup of dried fruit. Again, I'm using the colloquial rather than the botanical definition, so I place tomatoes in the other vegetables group. Common cruciferous vegetables include broccoli, cabbage, collards, and kale. I recommend at least 1 serving a day, typically a half cup, and at least 2 additional servings of greens a day, cruciferous or otherwise. Serving sizes for other greens and vegetables are a cup for raw leafy vegetables, a half cup for other raw or cooked non-leafy vegetables, and a quarter cup for dried mushrooms. Everyone should try to incorporate 1 tablespoon of ground flax seeds into their daily diet, in addition to a serving of nuts or other seeds. A quarter cup of nuts is considered a serving, or 2 tablespoons of nut or seed butters, including peanut butter. Chestnuts and coconuts, though, don't nutritionally count as nuts. I also recommend 1/4 teaspoon a day of the spice turmeric, along with any other salt-free herbs and spices you may enjoy. A serving of whole grains can be considered a half cup of hot cereal, such as oatmeal, cooked whole grains, or so-called pseudo-grains like amaranth, buckwheat, and quinoa, or a half cup of cooked pasta or corn kernels, a cup of ready-to-eat cold cereal, 1 tortilla or slice of bread, half a bagel or English muffin, or 3 cups of air-popped popcorn. The serving size in the beverage category is 1 glass, 12 ounces, and the recommended 5 glasses a day is in addition to the water you get naturally from the foods in your diet. I explain my rationale in my video, How Many Glasses of Water Should We Drink a Day? Finally, I advise 1 daily serving of exercise, which can be split up over the day. I recommend 90 minutes of moderate-intensity activity each day, such as brisk 4 miles per hour walking, or 40 minutes of vigorous activity, such as jogging or active sports, each day. I explain my reasoning for that in my video, How Much Should You Exercise? This may all sound like a lot of boxes to check, but it's easy to knock off a bunch at a time. 1 simple peanut butter banana sandwich, and you just checked off 4 boxes. Or imagine sitting down to a big salad, 2 cups of spinach, a handful of arugula, a handful of walnuts, a half cup of chickpeas, a half cup of red bell pepper, and a small tomato. You just knocked out 7 boxes in 1 dish. Sprinkle on your flax, add a handful of goji berries, and enjoy it with a glass of water and fruit for dessert, and you just wiped out nearly half your daily check boxes in a single meal. And then if you just ate it on your treadmill— just kidding. Do I check off each glass of water I drink? No. In fact, I don't even use the checklist anymore. I just used it initially as a tool to get me into a routine. Whenever I was sitting down to a meal, I would ask myself, could I add greens to this? Could I add beans to this? I always have an open can of beans in the fridge. Can I sprinkle on some flax or pumpkin seeds, or maybe some dried fruit? The checklist just got me into the habit of thinking, how can I make this meal even healthier? I also found the checklist help with grocery shopping. Although I always keep bags of frozen berries and greens in the freezer, if I'm at the store and want to buy fresh produce for the week, it helps me figure out how much kale or blueberries I need. The checklist also helps me picture what a meal might look like. Looking over the checklist, you'll see that there are 3 servings each of beans, fruits, and whole grains, and about twice as many vegetables in total than any other component. So glancing at my plate, I can imagine 1/4 of it filled with grains, 1/4 with legumes, and a half of the plate filled with vegetables, along with maybe a side salad and fruit for dessert. I happen to like one-bowl meals where everything's mixed together, but the checklist still helps me to visualize. Right? Instead of a big bowl of spaghetti with some veggies and lentils on top, I think of a big bowl of vegetables with some pasta and lentils mixed in. Instead of a big plate of quinoa with some stir-fried vegetables on top, I picture a meal that's mostly vegetables, and oh look, there's some quinoa and beans in there too. But there's no need to be obsessive about the Daily Dozen. On hectic travel days, when I've burned through my snacks, stuck in some airport food court somewhere, sometimes I'm lucky if I even hit a quarter of my goals. Right? If you eat poorly one day, just try to eat better the next. To help track your progress, volunteers created Dr. Greger's Daily Dozen apps for both iPhone and Android. You can download and use them both for free, no ads, no cost. My hope is that the checklist will just serve as a helpful reminder to try to eat a variety of some of the healthiest foods every day. If you look at Avocado Board-sponsored reviews, they like to brag that avocados are the richest known fruit source of phytosterols, which are cholesterol-lowering nutrients found in plant foods. The operative word, though, is fruit. Yes, there are more phytosterols in avocados compared to other fruit, but the reason that's such a misleading statement is that phytosterols are fat-soluble substances. Most other fruits hardly have any fat in them at all, so of course avocados are going to come out on top compared to other fruit. But let's compare phytosterol content of avocados to nuts and seeds. One avocado has about 100 milligrams of phytosterols, but on the same scale, sesame seeds and tahini have 400. Pistachios, pumpkin seeds, and sunflower seeds have about 300, and almonds and almond butter, flax seeds, and macadamia nuts have around 200. Even chocolate has about twice as many phytosterols as avocado. Even though nuts and seeds have the highest levels overall, the studies that have been done on lowering cholesterol, lowering LDL bad cholesterol with phytosterols, have used supplements starting at 600 milligrams up into the thousands. So yeah, you can lower LDL cholesterol about 8% at up around 2,100 milligrams, but that would be 20 avocados a day. That would also be a lot of nuts. But you can get an 8% drop in LDL just eating a palmful of nuts a day, a single ounce. So phytosterols are not the only components of nuts responsible for driving down cholesterol. There must be other components in nuts, like maybe the fiber or other phytonutrients, that are contributing to the cholesterol-lowering effects. I wonder if avocados have such components too. You don't know until you put it to the test. There are studies dating back more than a half-century that appear to show that if you add an avocado to people's daily diets, their cholesterol drops, and then goes back up when you remove the avocados, then goes back down again. Pretty convincing data, until you see how the study was done. They didn't just add an avocado, they swapped out animal fat. No wonder their cholesterol went down. So this may just as well read on lard, off lard, on lard, off lard. And that's what nearly all avocado cholesterol studies are like. 10 studies involving hundreds of people, and put them all together, and looks like adding avocados led to a significant drop in cholesterol and triglycerides, an average of about a 17-point drop in bad cholesterol. But these were nearly all strictly substitution studies, where they removed saturated fat from people's diets and substituted in avocados. Well, of course, if you cut down on saturated animal fat, your cholesterol is going to drop. You can tell this review was not funded by the avocado industry because they point this out. It's important to note that substituting avocados for saturated dietary fats, as opposed to adding avocado to an already established baseline diet, poses the greatest benefit. Just adding avocado may confer no cholesterol benefits at all. So yeah, the avocado industry is right in saying that avocados are a healthy substitute for butter, margarine, cheese, and cream cheese, but that's a pretty low bar. When one sees headlines like, "Avocados can improve your cholesterol," they're largely talking about substitution experiments, where avocado is added to the diet by replacing animal fats. So no wonder cholesterol goes down. So for example, if you take people eating a standard North American diet, including animal fats, dairy and poultry are the two greatest contributors of cholesterol-raising saturated fat intake. They may start out with an LDL up around here. Just add avocado to their diet without doing anything else, and cholesterol does not go down. But add avocado while reducing saturated fat intake, and cholesterol falls. But no more than just reducing saturated fat while adding nothing. OK, but what if you eat no meat at all versus no meat with avocado added? They took people with sky-high cholesterol, up around 300, and switched them to a relatively low-fat vegetarian diet with about 20% of calories from fat, versus a vegetarian diet with added avocado, bringing it up to more of a typical fat content, 30% of calories from fat. This group started out with LDLs through the roof, and while cutting out meat may have helped, cutting out meat and adding avocado seemed to help even more. And it may help best with the worst type of LDL. As I've touched on before, all LDL cholesterol is bad cholesterol, but large, fluffy LDL may only increase the odds of cardiac events like heart attacks 31%, whereas small, dense LDL is even worse. Feed people lots of oatmeal and oat bran, and not only does their LDL go down overall, but it specifically brings down the worst of the worst. Add walnuts to a low-fat diet, and not only does LDL go down, but the size distribution of the LDL shifts to a little more benign as well. And if you put people on a plant-based diet with lots of fiber and nuts, you can get a massive 30% drop in LDL, comparable to a cholesterol-lowering statin drug. And this includes the small, dense, most dangerous LDL. Note this does not happen with extra virgin olive oil, so it's not just a monounsaturated fat effect. In the famous Predimed study, those randomized to extra nuts got a significant drop in the smallest, densest LDL, but those randomized to the extra virgin olive oil group did not. So there appears to be some special components in nuts that lowers the worst of the worst. Do avocados offer similar benefits? We didn't know until now. The first randomized controlled feeding trial to look at avocados and LDL size. What they did was remove animal fat from people's diet and replaced it with either carbs, or avocado, or vegetable oils that had a similar fat profile to the avocado. So the two latter diets were very similar diets, but one had the nutrients unique to the avocado, and the other didn't. What happened? Well, anytime you drop saturated fat, you're going to bring down LDL, whether you replace animal fat with plant fat, oil in this case, or with carbs. But what if you replace animal fat with the whole plant food avocado? An even better effect. And to see why, they broke the LDL down into large versus small. They all brought the dangerous large LDL down, but the avocado had the additional effect of also bringing down the super dangerous small LDL. That's where that extra drop came from. So it's not just a matter of replacing animal fat with plant fat. There are additional benefits to the fiber and phytonutrients of whole plant foods, like avocados. Oh, there's something good in avocados? Well then, let's just add avocado extracts to the meat. Incorporating avocado extracts into pork patties evidently reduces cholesterol oxidation products, well documented to be toxic, carcinogenic, and atherosclerotic, but less so, apparently, with some avocado mixed in. When some misinformed people hear of the grand opening of a new plant-based medical practice, one plant in particular may come to mind. Over the years, I've gotten a lot of questions about cannabis, and I figure it's high time to try to clear the haze. I didn't want to just take a pot-shot token effort and end up with some half-baked puff piece, there are burning issues about a growing industry. With so much buzz and smoke and mirrors, the science can really take a hit. Are there acute chronic effects? Blunt trauma from impaired driving, perhaps? I wanted to give the straight dope, weed out any dubious research, and it's been quite a trip. 420 articles published within just the past few months. This is the review everyone was waiting for. The 2017 Current State of Evidence from the Institute of Medicine, tasked with conducting a comprehensive review on the health effects of cannabis. Started out with 24,000 sources, whittled it down to about 10,000 to produce this 468-page document. What did they find? I think it's fair to summarize that they found the purported benefits to be much smaller and weaker than are often reported, but so too the purported risks. So good news for the recreational user, who is mostly just worried about not getting cancer, but bad news for the patient who actually wants it to help their cancer. The only three benefits they could find substantial evidence for was as a treatment for chronic pain in adults, chemo-induced nausea and vomiting, and relieving self-reported muscle tightness in patients with MS. Even archetypal medical marijuana indications like glaucoma failed to live up to expectations. Despite popular belief to the contrary, extensive research over decades has documented that marijuana is not effective in the management of clinical glaucoma, a disease of increased pressure within the eyeball. It does lower pressure, but only for about an hour, and so you'd have to smoke a dozen joints a day. And even if you did smoke those few thousand a year, your body gets used to it, and so what little benefit there is disappears within a few months in most patients. On the other hand, conspicuously missing from this list of adverse side effects of long-term or heavy use is any mention of chronic obstructive pulmonary diseases like emphysema, which you can get from smoking tobacco. And similarly, it doesn't look like smoking marijuana increases the risk of respiratory cancers like lung cancer or head and neck cancer, though cannabis may increase the risk of testicular cancer. There have been 3 studies so far on marijuana use and testicular cancer, appearing to increase risk about 50%, but only, it seems, for those smoking once a week or more, or for 10 years or longer. So what did they conclude overall? Were they for legalization, opposed? Basically, they concluded there simply isn't enough research, leaving patients, healthcare professionals, and policymakers without the evidence they need to make sound decisions either way. Further, this lack of evidence-based information poses a public health risk. That's one thing everyone on both sides can agree on: the need for definitive clinical research. Otherwise, we're just left with anecdotes, blogs, and ads which don't provide a sound basis for assessing the safety and efficacy of pharmacologic agents. Because cannabis is just a naturally occurring plant and cannot be patented, the pharmaceutical industry is MIA. What we need are large clinical trials. Until then, we're all just going to be scratching our heads. But where's the funding going to come from? For drug companies, interest in the plant is scant. Where's the payback? Big Pharma is interested in a reasoned approach, however. The development of newer cannabinoid modulators in profitable pill form will one day, writes this pharmacology professor, make the use of herbal cannabis a thing of the past. Why is there such a dearth of rigorous research on the effects of marijuana? The first major study wasn't published until 2007. Why did it take so long? Why did the pharmaceutical industry fail to show any interest? Some might prefer a simple answer. Since it's just a plant, it can't be patented for your stockholders, thus removing any incentive for investing corporate funds. Yes, but it's more complicated than just that. There are research funds available, $100 million of public money in a single year, but historically, that money was generally obtainable only for research on the negative effects. See, in the U.S., cannabis is still officially lumped in with heroin as a Schedule I drug, which means by definition it's classified by the government to have no medicinal value, a designation that resulted in a near cessation of scientific research, particularly since the only way researchers could get it without risking jail time is a state-run farm in Mississippi, controlled by the National Institute on Drug Abuse, which has historically only green-lighted research aimed at demonstrating harmful effects. Residents of 23 states can walk out and just buy it, but U.S. scientists must wade through onerous paperwork, and even when they do get it, it's the wrong stuff. It's not what people are actually using these days. The studies coming out are on like your grandma's grass, a few percent THC, where the stuff available these days may be 10 times more potent. So there's like this crazy catch-22, where the cannabis that should be studied is illegal, and the cannabis that can be legally studied, the decades-old Mississippi strain, is essentially kept off-limits. So ill-informed practitioners are thus left to make do with anecdotes off the internet like everybody else, which is bad medicine. As long as clinical research on cannabis is controlled by regulators expressly opposed to the stuff, we may miss out on potential benefits. That's no excuse, though. Just because there are political barriers to research doesn't mean we should lower our bar in terms of demanding evidence. The sick still need medically sound treatments. Of course, now there's pressure coming from both sides. The marijuana industry is now big business, and with those billions can rally the troops. Cannabis researchers already talk of being bombarded with emails from pro-cannabis groups if they dare make any negative comments about the drug. Marijuana research is like tobacco research in the 60s, says one University of Colorado researcher, and so now there's fear big money will push the pendulum too far the other way. But the barriers go beyond money, politics, and prejudice. Cannabis research is hard to do. How do you do a double-blind study with marijuana? People know when they've been duped with placebo dope. People can tell the difference between pot brownies and regular brownies. Otherwise, they wouldn't eat them. And so if you know you're getting the active drug, the placebo effect can kick in hard, notes one neurobiology researcher, especially when you're dealing with subjective outcomes like pain or mood. And imagine if you're trying to do a population study on memory or cognitive impairment, and you're asking heavy pot smokers to try to remember how much they've been smoking over their life. You can imagine how that might influence data accuracy. Let me give you an example of how convoluted this can get. Neuropsychological testing of cannabis users have found residual negative effects in terms of scoring slightly lower on memory tests. But how do we know it's not a matter of motivation rather than actual cognitive impairment? That had never been tested until this study. They gave a group of potheads a standard learning test and just gave the standard spiel. Please complete the following series of tasks which measure different areas of cognition like memory and attention. That's what you'd normally say. And when you do, pot smokers score significantly worse. But what if you instead said this? Please complete the following series of tasks. It's important that you try your very best on these tasks because this research will be used to support legislation on marijuana policy. So hey, if you do good, they might decriminalize weed or something, and under those circumstances, boom, the apparent cognitive impairment disappears. Now you could argue that lack of motivation is a problem in and of itself, but hey, it's better than having long-term brain damage. If you randomly select a group of women and ultrasound their uterus, the majority of them have fibroid tumors by age 50. And by most, I mean more than 80% of black women, and about nearly 70% of white women. Half of white women already have fibroids by their early 40s, and the same could be said for African-American women in their mid-30s. After getting over the shock of how widespread fibroids are, The next question becomes, why the racial disparity? Is it diet, stress, environmental exposures? Maybe whatever it is could offer a clue as to what causes fibroids. For example, African Americans tend to have a lower intake of fruits and vegetables, and fruits and vegetables appear protective against fibroids, particularly citrus, here in the Black Women's Health Study, though not apparently just citrus juice. It's interesting, if you measure the levels of beta-carotene in fresh surgical tissue samples of uterine fibroids, and adjacent normal uterus tissue obtained during hysterectomies, you find significantly lower concentrations in the fibroids. In fact, beta-carotene was not even detectable in half the fibroid specimens. The same thing is actually found in cancer. Most cancerous tissues tested had undetectable levels of beta-carotene compared to the normal tissue right next to the tumor. So maybe decreased levels of beta-carotene somehow plays a role in causing these conditions? Sounds like a bit of a stretch, but you don't know until you put it to the test. But there had never been a randomized controlled clinical trial of fruits and vegetables for fibroids until never. They did do a randomized controlled trial of a kind of a fruit and vegetable at the same time, tomatoes, but for the prevention of fibroids in Japanese quail. And most of my patients are not Japanese, nor quail. The action of lycopene, the red pigment in tomatoes, in an animal model may not accurately represent lycopene action in humans. And indeed, the Harvard nurses study found no apparent link between lycopene consumption and fibroids. So yeah, fruits and at least green vegetables may have a protective effect, but we won't know for sure until they're properly put to the test. Vitamin D is another possibility as to why African Americans disproportionately suffer from fibroids. Women with darker skin are more likely to be vitamin D deficient. As many as 80% of black women may have inadequate levels of vitamin D, compared to only 1 in 5 white women. Vitamin D does inhibit fibroid cell proliferation in a petri dish. It may be able to shrink tumors in your pet rat, but what about people? A population study did find that women with sufficient vitamin D levels in their blood had about a third lower odds of fibroids, consistent with the finding that women who report lots of sun exposure also appear to be protected. But until there's an interventional trial where women are randomized to vitamin D or placebo, we won't know for sure if vitamin D plays a role in fibroid prevention or treatment or not. African American women are also more likely to sprinkle baby powder on their genitals, which may not only double the odds of fibroids, but may increase the risk of ovarian cancer, the deadliest gynecological cancer. Internal memos show Johnson & Johnson knew about the cancer risk, but still decided to target African Americans. Think of us, Johnson & Johnson said, as a lifetime friend of the family, a lifetime cut short, perhaps, by its baby powder. Or at least so said a jury, which recently awarded a family $110 million in damages, on top of the $200 million in verdicts from last year, with thousands of lawsuits pending, after internal memos revealed that decades ago their own contracted toxicologists were warning the company that there are multiple studies showing a cancer link, and anyone who denies this risk will be perceived by the public in the same light as those who denied a link between smoking cigarettes and cancer, denying the obvious in the face of all evidence to the contrary. The half-life of lead in the bloodstream is only about a month. That means if you feed people lead for about 100 days, their blood levels go up, and then if you stop, the lead levels in the blood start to drop, such that within about 30 days your lead levels are cut in half, and another month cut in half again, such that by 3 or so months your body is able to remove about 90% from your bloodstream. Now, if you're chronically exposed to lead, you can have chronically high lead levels in your blood. More than 500,000 kids in the U.S. have concerningly high lead levels, and poor people and politically disempowered communities of color are at higher risk regardless of age. But if you don't live in those communities, aren't constantly exposed to lead, why should you care about dietary strategies to lower the lead level in your own blood if your body is already so good at it? Even if you get exposed to lead here and there, 3 or 4 months, and 90% of the lead in your blood is gone. But the question is, gone where? More than 90% of lead in our body is stored in our bone. And instead of a few months to get rid of it, how about a few decades? So even if we moved to some other planet and had zero further exposure to external sources of lead, we still have an internal source of lead leaching the toxic heavy metal into our system throughout our life. But if it's mostly just socked away in our skeleton, what's the big deal? Well, if you were to lose bone, all the trapped lead could come flooding back into your system. For example, when we lose weight, we lose bone, which makes a lot of sense. Heavier people have a heavier skeleton, greater bone mineral density. Their body has to maintain stronger bones to carry around all that extra weight. So if we lose weight, do the levels of lead in our bloodstream go up as our skeleton downsizes? Unfortunately, yes. But only if we lose a lot of weight. Lose 10 pounds or so and not much happens, but lose more like 80 pounds and the lead levels in your blood can rise 250%. When else can you experience bone loss? Well, osteoporosis, obviously. Women with osteoporosis can lose an average of 3% of their bone mass a year. But even healthy postmenopausal women without osteoporosis may lose a percentage of their skeleton annually. So do the lead levels in women go up when they lose their periods? Apparently so. A study of nearly 3,000 women found a significant increase in lead levels after menopause, providing evidence that bone lead is in fact mobilized into the blood. A major implication is that even low-level lead exposure over a relatively long time may result in increased body burdens of lead, which would be releasable in toxicologically significant amounts during physiological states where your bone is in flux. Not just osteoporosis, but most seriously during pregnancy and lactation. Now, most of the calcium the baby gets comes from increased maternal absorption of dietary calcium. The mother's gut starts absorbing 60 or 70% more calcium in the second or third trimester to build the baby's skeleton. That's why women's dietary calcium requirements are not increased by pregnancy or breastfeeding. Your body's not stupid. When it realizes it needs more calcium, it just absorbs more calcium. Now, when that isn't enough, you do end up dipping into the calcium stored in your bones. But not a problem. After it's all over, your body puts the calcium back into your skeleton, such that 6 months after delivery, your bone mineral density is right back where you started. That's why even women who breastfeed for a long time, well past those 6 months, in pregnancy after pregnancy after pregnancy after pregnancy, end up with no compromise to their bone mineral density later in life, whether measured in their wrists, spine, or hips. So what if your body makes a withdrawal from the bone bank during pregnancy and lactation if it ends up just depositing it all back? Because of the lead. When your body dissolves some of your bone to borrow that extra calcium, it releases the lead that's locked in there at the worst possible moment, right when your baby is most vulnerable. That's part of lead's toxic legacy. Although our skeleton has predominantly been considered a storage site for sequestering absorbed lead, bone is not simply an inert storage site. Once deposited in bone, lead can be remobilized from bone back into the bloodstream if we lose bone, for example, osteoporosis. Even just normal menopause can do it, rising lead levels as our bones start to lose their integrity. But it's the mobilization of long-term stores of lead from maternal skeleton during pregnancy and lactation that's the biggest concern. So to maintain maternal lead levels as low as possible during this critical period, we need to minimize bone loss. How do we do that? Well, habitual excessive salt intake could be a factor in promoting bone loss. So is there a relationship between maternal sodium intake and blood lead levels during pregnancy? We didn't know until this study. They did find that higher salt intake was associated with higher lead levels, but only for women who were getting less than 840 milligrams of calcium a day. This suggests that adequate calcium with low sodium intake may play a beneficial role in decreasing the blood lead concentration in pregnant women. Higher calcium intake has been associated with lower blood lead concentrations during pregnancy, but you don't know if it's cause and effect unless you put it to the test. What if you gave women calcium supplements? We explored previously how milk may actually make things worse. What about just straight calcium, especially for women with low calcium intake? These poor African women, getting only 350 milligrams of calcium a day, just 35% of the 1,000 milligram RDA. Let's step in and give them a whopping 1,500 milligrams of calcium a day. That will protect their bones. How did they ever get along without us? Without the calcium, just getting 350 milligrams of calcium a day in their diet, they lost some bone in their spine and hip, but the group we gave, in our wisdom, 1,500 milligrams of calcium a day to, lost even more bone. Those women who had received the calcium supplements had a significantly lower bone mineral density at the hip and greater bone loss in the spine and wrists. Oops. What happened? It looks like we messed up their body's natural adaptation. Remember, they were only eating 350 milligrams of calcium a day, so their body wasn't stupid and was maximizing absorption, minimizing loss, and then we step in with calcium pills and undermine the whole process, turn off those adaptations, leave their body thinking they were always going to get these massive doses, and then when the study stopped, they went into major calcium deficit and had to steal more from their bones. The researchers went back later, hoping they'd catch back up, and while the women lucky enough to have ended up in the placebo group bounced back, those given the extra calcium continued to suffer the effects. What about in Western women, though, already taking in over 1,000 milligrams a day? Would giving them an extra 1,200 milligrams a day cut down on some of that bone flux? Yes, it did seem to cut down on bone resorption by about 16%, and thus may constitute a practical intervention to prevent the transient skeletal loss associated with childbearing, which could release any lead trapped there. But you don't know until you put it to the test. This is a different paper from the same study. The researchers measured what was happening to their lead levels, and that drop in bone borrowing led to a drop in lead release, and so may help lower exposure to the fetus, as well as the infant, as the benefits continue through breastfeeding. OK, these were women living in Mexico City who may have been exposed to lead-glazed ceramics, with lead levels approaching 10. What about for women with lead levels closer to the current U.S. average, under 5? We didn't know until you put it to the test. Well, half the breastfeeding women were randomized to take 500 milligrams of extra calcium a day. Their lead levels started out the same during pregnancy, but shot up during breastfeeding, as presumably some of the lead was released from their bones. But that was in the regular non-supplemented group. In the group that got the 500-a-day calcium supplement, there was no spike in lead in their bloodstream, providing evidence that calcium supplementation during breastfeeding may be effective in limiting mobilization of lead from bone stores, thus reducing the risk of lead transfer to the nursing infant through breast milk. Now, breast is still best regardless, supplementation or not. The risks are outweighed by the benefits of breastfeeding, but calcium supplementation may help reduce any risk even further. Of course, better to not build up lead in your bones in the first place. As a famous occupational medicine paper put it a half-century ago, yes, there's all methods of dietary interventions. There's only one way, and one way only, to prevent lead poisoning: not get poisoned in the first place. Anything else just diverts attention from treating the underlying cause. For other toxic heavy metals like mercury, for example, that would mean advising women to avoid the consumption of fish that eat other fish during pregnancy, and when breastfeeding to decrease mercury levels in breast milk, in fact, maybe even before pregnancy, women of childbearing age period, so you don't build up mercury in your body in the first place. For lead, That means not living next to a smelter plant, avoiding smoking. Now, there's one other way to detox your body of lead to protect some of your future children, but it's not ideal. Remember that menopause study, where postmenopausal women had higher blood lead levels than premenopausal women? Well, even higher still were postmenopausal women who never had children. The postmenopausal increase in lead levels was less in women with prior pregnancies, presumably because they'd already detoxed some of their lead into their children. When women hit menopause and their ovaries shut down, the estrogen level in their body drops 95%. This is good news for the endometrium, the lining of the uterus. Otherwise, the constant estrogen signaling could eventually result in endometrial cancer. In fact, maybe that's why menopause evolved, to protect the uterus from cancer. Lower estrogen levels are also good for lowering breast cancer risk. In postmenopausal women, relatively high blood levels of estrogen are associated with more than double increased risk for breast cancer. Estrogen levels drop 95% at menopause, but not to zero, because other tissues can make estrogen, like our own fat cells. This probably explains the increase in breast cancer risk in obese postmenopausal women. More fatty tissue means more estrogen production. Now, we learned that soy phytoestrogens can block the production of estrogen, such that drinking a glass of soy milk with each meal can cut estrogen levels in half in premenopausal women. But levels in postmenopausal women are already down 95%, and because of that, many women suffer from hot flashes. Might lowering levels even further with soy make menopausal symptoms even worse? Estrogen treatment, very effective in reducing menopausal symptoms. Unfortunately, the downside is not only the uterine cancer, but blood clots, strokes, and cognitive impairment. Taking progesterone-type compounds with the estrogen helps prevent the uterine cancer, but increases the risk of heart attacks, more stroke risk, breast cancer, more clots, and dementia. So what's a woman to do? Well, the 80% hot flashes figure is not universal. Maybe 80 to 85% in European and American women, but it may be as low as just 15% in places like Japan. In fact, there's not even a word for it in the Japanese language, which supports how relatively rare it is. Maybe the phytoestrogens in soy are helping? The association between soy product intake and the occurrence of hot flashes was examined by following 1,000 Japanese women before they started menopause over time to see who developed hot flashes and who didn't. And those women who were eating like 4 ounces of tofu a day appeared to cut their risk in half compared to women who only ate like an ounce or 2 a day, suggesting soy products are protective. But maybe soy intake is just a marker for a healthier diet overall? A study in China found that consumption of whole plant foods in general seemed to be associated with decreased menopausal symptoms. So to see if soy was something special, you'd have to put it to the test. Studies like this of soy phytoestrogens in pill form showed extraordinary results, a significant drop in hot flash presence, number, and severity, from 100% of women suffering at the beginning to only 31% suffering by the end of 3 months. The average number of hot flashes dropped from about 120 a month down to 12. But the problem with studies like these is that there's no control group to control for the placebo effect. If you look at all the hormone trials, even the women who got the placebo sugar pills had up to a 60% reduction in hot flashes over the years. That's why any therapy purported to reduce such symptoms must be assessed in blinded trials against the placebo because of the large placebo effect, and also because menopausal symptoms often decline on their own over time. So if you saw a study like this, where they gave women a soy protein powder and saw a nice drop in hot flashes over the next 12 weeks, you'd think, it looks pretty effective. But that's the placebo powder group. Here's the group that got the soy, significantly better than placebo. But it's important to recognize how powerful the placebo effect can be. Over the past 20 years, more than 50 clinical trials have evaluated the effects of soy foods and supplements on the alleviation of hot flashes. Compiling the best ones together, the placebo groups got about a 20% drop in hot flash severity. The soy groups achieved about a 45% drop, so on average the soy did about 25% better than control. There have been 2 studies that compared soy phytoestrogens head-to-head against hormones, and in one study they actually seemed pretty comparable in terms of reducing hot flashes, muscle and joint pain, and vaginal dryness compared to placebo, though in the other, soy did better than placebo, but estrogen and progesterone therapy did better than them both. But the soy has the benefit of not increasing cancer, heart disease, and stroke risk. Menopause is characterized by a decrease in estrogen, which triggers the uncomfortable symptoms of hot flushes, night sweats, sleep disturbances, and vaginal dryness. Among these menopausal symptoms, hot flushes, also known as hot flashes, are reported by many women to be the most bothersome. I already summarized the available evidence on the role of soy phytoestrogens to alleviate those symptoms. Here's the latest meta-analysis. Although the balance of evidence point to soy benefits, the individual study results are all over the place. Yes, some studies showed 20, 30, even 40% better than control, but some showed no effect. This is something that's been noted by the professional societies, like the American College of OBGYNs. Yes, these supplements may work, but the evidence is so inconsistent. This may be partly because the supplements used were extracted from different parts of the soybean. Maybe it would be better if they just used soy foods rather than supplements. The dosing would be about 2 servings of traditional soy foods a day, like 2 cups of soy milk, which is what you see older women in Japan doing, who have some of the lowest reported rates of hot flashes in the world. But even the studies on soy foods, as opposed to supplements, have had conflicting results. Why all the inconsistency? It may have to do with our gut bacteria. People who eat foods made from soybeans, which have these health-promoting isoflavones, tend to have lower rates of a variety of chronic diseases. So we can garner this protection by eating more soy foods, right? Well, it may be a little more complicated than that. There are certain gut bacteria that can convert isoflavones in soy into a potentially even more beneficial compound called equol. Not all individuals can make this conversion, though, because not all individuals have the specific types of good bacteria in their gut that do it. So there's 2 types of people in the world, equol producers and equol non-producers, depending on their gut flora. And so this may help account for the variations in health benefits we see in clinical studies. It may help explain why some people seem to benefit from soy more than others. For example, in the study I covered before about how soy milk appears to prevent bone loss in the spines of postmenopausal women, if you split the women into equol producers and non-producers, soy did work in non-equol producers, but seemed to work even better in the women whose gut bacteria is able to take the soy to the next level. The more equol Japanese women make from the soy they eat, the fewer menopausal symptoms they may have. Some studies suggest equol-producing men may get less prostate cancer. If that's the case, maybe we should look into improving the intestinal environment to enable equol production. Only a minority of the Western adult population is able to produce equol, though almost every other animal species appears to produce it no problem. In fact, that's how it got its name. It's named equol because it was first discovered in horses. But, interestingly, horses during the summer, not winter, because that's when their gut bacteria had access to the phytoestrogens in clover. That was our first clue equol was made from plants. If you're not Mr. Ed, though, can you take someone who doesn't make equol and convert them into an equol producer? Certainly you can do the reverse. Excessive use of antibiotics can wipe out your good bugs. But how can you acquire the right good bugs? Suggested strategies include dietary alteration or probiotics. The standard probiotic regimens don't seem to help, so how about dietary alteration? Well, about half of Japanese and Korean individuals can produce equal, but only as low as 1 in 7 Americans. Maybe it's because more soy is eaten in Asia? That would make sense. If you eat a lot of soy, you may foster the growth of bacteria in your gut that can digest soy. But a month of soy isoflavone supplement exposure didn't seem to convert non-producers into producers. But just 2 weeks of drinking 3 glasses of soy milk a day was able to convert 3 of 6 women into producers. For example, this woman started out not making any at all, or maybe a little bump between hours 50 and 60, but after 2 weeks of drinking soy milk, when they had her drink some more, she had nice equal spikes. It didn't work for all women, though, and when they tried the same experiment in men, nothing happened. All right, back to the drawing board. Is there any group of Westerners that have high equal production rates that may offer a clue? Vegetarians have among the highest equal production rates ever recorded, more than 4 times as likely to be equal producers as their non-vegetarian counterparts. The question is, why? They don't think it's because of the soy, given the conflicting soy data. Maybe it's because they're eating more prebiotics like fiber? Or maybe dietary fat intake decreases the capacity of gut flora to make equal. Or maybe it has something to do with cholesterol intake. Analyzing the diets of equal producers, they do seem more likely to be eating more carbs, plant protein, and fiber, but researchers have tried giving people fiber supplements along with soy, but that didn't seem to work. Whatever it is about those eating plant-based diets, they may soon be the only remaining majority equal producers as Asian populations continue to westernize their diets. Natural immunomodulators are getting more and more popular, things that might naturally regulate our immune system. That popularity, however, often brings over-optimistic claims and mediocre effects. Such mythical beasts have been sought after for centuries. The current market is full of all sorts of supplements promising the golden fleece, inexpensive, no side effects, yet actively boosting our immune system. Many simply repeat unjustified claims with hardly any science to support them. On the other hand, there is beta-glucan, which has undergone 10,000 scientific studies and clinical trials. Wait, what? Beta-glucan is the fiber in nutritional yeast I talked about before, able to decrease episodes of common illnesses in young children. But what about in adults? First of all, why can't they just come up with a vaccine against the common cold virus? Because there is no single common cold virus. There are hundreds of different viruses implicated in causing cold-like symptoms. So that's why there's so much interest in finding a general, non-specific immune booster across the board. Beta-glucan supplementation can increase the levels of immunoglobulin A in the saliva within 4 days at a daily dose of 400 mg, but not 100 mg, so the amount found in about 2 teaspoons of nutritional yeast a day, but not a half teaspoon. IgA is an antibody that plays a crucial role in the immune function of our moist membranes like eyes, nose, and mouth. 1 teaspoon's worth didn't do much until they exercised. 2 hours after a strenuous 50-minute bout of strenuous cycling in a hot, humid environment, those who had been on the yeast beta-glucan did get that IgA boost. Beta-glucans failed, however, to boost the antimicrobial activity of white blood cells taken from subjects who had been taking like a tablespoon's worth a day. What we care about, though, are clinical outcomes. Do those consuming beta-glucans suffer significantly fewer infections? OK, how about a double-blind, randomized, placebo-controlled nutritional study to see if yeast beta-glucan can improve our immune defense system? 100 people followed for 26 weeks, 50 getting about a tablespoon of nutritional yeast worth of beta-glucan a day, 50 getting placebo, and they just counted how many episodes of the common cold they got, and there was no significant difference. Now, if you just look at the first half of the time during cold season, there did appear to be fewer infections in the active group, meaning the beta-glucan group, but this is what's called a post hoc analysis, where you go back and look at your data after the fact, which is frowned upon by the scientific community because it increases the likelihood that your findings are just due to chance. But those who did end up getting sick while on the beta-glucan did genuinely appear to suffer milder symptoms. A similar larger study had similar findings. Maybe the severity of the colds was lessened, but in the main analysis, no significant difference in the number of times people got colds in the first place. Same in other studies. No significant differences in the number of symptomatic respiratory infection episodes. No significant effect on upper respiratory tract infection outcomes, so overall, pretty disappointing results. But wait a second. What about my video about preserving immune function in athletes with nutritional yeast? They found a significant drop in cold symptoms 2 weeks and 4 weeks after a marathon at both 1 teaspoon of yeast worth of beta-glucan a day and 2 teaspoons. Yeah, but they had just run a marathon. Remember this study where the effect only seemed to emerge after strenuous exercise? That's where beta-glucan seems to shine, counteracting the toll extreme physical exertion can have on our immune function. In an athlete, that just may mean some lost practice days or something. But for soldiers or firefighters, maintaining one's health, even in the context of heavy physical stress, could be critical. OK, but that's counteracting the effects of physical stress. What about mental stress? Stressful life events can impair our moist membrane defenses, such that psychological stress has also been shown to increase susceptibility to the common cold, getting more colds and worse colds than people under less stress. So let's see if we can help. And indeed, in this study of healthy women under moderate levels of perceived psychological stress, those taking about a teaspoon of nutritional yeast a day worth of beta-glucans for 12 weeks were 60% less likely to report experiencing symptoms like sore throat, stuffed or runny nose, or cough, strongly suggesting that bakers, brewers, and nutritional yeast beta-glucan is able to counteract the negative effects of stress on the immune system. And they experienced 41% greater vigor, which is a measure that encompasses physical energy, mental acuity, and emotional well-being. So they just felt better too. Put all the studies together, and yeast beta-glucans do appear to have immune-strengthening effects, at least in children, and those under physical or mental stress. When people have asked me if microwave ovens are hazardous, my typical snide response is yes, if you drop them on your foot. But it turns out that's actually a real thing. Hundreds of Americans end up in the emergency room every year because a microwave dropped on them. Or they hurt their back trying to lift one, or falling onto a microwave oven. I'm not sure how that works. Maybe they tripped on it. But the majority of microwave injuries involve scalding oneself on hot foods or liquids. But when people go to PubMed and search the medical literature and see all these scary-sounding titles about the hazards of microwave ovens, they may not realize these are like articles about jelly donuts. Hazards of a microwave oven. An adolescent patient, ravenously hungry, rushed home from school for his afternoon snack, found a jelly donut, popped it in the microwave. The outside was just comfortably warm, and so he gulped it down before the searing pain started from the burning jelly inside, and he had to go to the hospital. And that's the tricky thing about microwave cooking. With conventional cooking, the outside is hotter than the inside, but with microwaving, the inside can get burning hot, even while the outside remains relatively cool. Now, there's still a lot more kids getting burned from regular stoves. The injuries related to stove use vastly exceed those associated with microwave ovens. Over a 5-year period, about 40,000 compared to 5,000 with microwaves, and the stove burns tend to be more severe as well. In fact, you know how you're never supposed to heat infant formula in a microwave, since you may not be able to judge the heat of the contents just by feeling the outside of the bottle? Well, if you heed that warning and use a pot or bowl of hot water to warm it instead, you may actually end up with higher burn risk from accidentally knocking over scalding water. So what's their solution? they suggest not warming it up at all. And that's basically just a cultural thing that we feel the need to warm it. Or even better, how about not bottle feeding it all and go for scald-proof milk at perfect body temperature? And when it comes to food, whether it's a jelly donut, or jelly roll, or microwave treacle tart, or a cheese pie, basically anything that's kind of soft in the middle can present a problem. But look, anytime there's anything liquid inside, can't you just open it up and let it cool before you eat it? What's the big deal? That brings us to the case of the exploding egg. Although there are many mishaps regarding the microwave, the most pertinent for pediatric patients seems to be the exploding egg. When heated in the microwave, the yolk absorbs the energy, getting overheated and pressurized, and both the yolk membrane and shell acts as a pressure barrier, and any disturbance can make it go boom. There have even been cases in which the shells have been cracked open, but then it still explodes when the yolk membrane was pierced with a fork. And the explosion can be so powerful and sudden that it exceeds the blinking reflex, leaving the eyes unprotected, which can lead to vision-threatening injuries. Normally it's just facial burns, but her poor brother had his face right over the plate and got his eyes burned and ended up in the hospital. Ophthalmologists should be aware of the serious risk and caution the public against the dangers of cooking eggs in microwave ovens. But come on, how common is this? There's all sorts of quirky case reports in the medical literature, like people getting eye injuries from eggs thrown out on Halloween or something. But if you do a search, there do seem to be a bunch of papers on exploding eggs. But I figured the best way to tell if this was a real phenomenon would be to search on YouTube, and holy moly, 25,000 videos, including one with more than 1 million views. Do not try this at home. There's even an article in a journal on teaching physics about how to use microwave ovens to perform exciting demonstrations, like spectacular egg explosions, denting the metal wall, blowing the door open, and making the whole oven jump up. Now, if the eggs just exploded inside, that's one thing, but the problem is that it can happen at the table. You sit down to eat them, and then boom. The majority of egg injuries are to the face, eyes, and nose, but it can also explode straight into your mouth and put you in the hospital. Microwave oven manufacturers evidently specifically warn against microwaving eggs intact, and advise not only removing the shell, but piercing the yolk prior to cooking. Even reheating can be a problem. She was just carrying it in a bowl to the dining room when it exploded, rupturing her eye, causing a serious enough injury that this group of ophthalmologists were like, look, forget just putting it in the instruction manual. Maybe there should be a warning about eggs on the microwave itself. About 20 people a day end up in American emergency rooms from microwave oven-related injuries, a few from microwave popcorn steam, overheated hair removal wax, nearly one a day from exploding eggs, but most are from overheated water. See, when you boil water on the stove, bubbles rise from the bottom, and as they burst, the excess heat is dissipated. Water heated in a microwave oven, though, may not bubble, and so can get even hotter than normal boiling temperature. Then if you sprinkle in some powder, tiny air bubbles are carried into the liquid and can expand into steam bubbles and erupt onto your hand. The FDA warns to be careful when trying to boil water in a microwave, particularly in a shiny container, or more than once, or for too long, or when not letting it cool down a bit first, or when dumping something into it. Most microwave-related burns in young children occur when the child reaches in to grab something hot. Toddlers as young as 18 months can open a microwave, so some public health advocates have recommended that instead of just warning people to let stuff cool first for a few minutes, there should be some kind of door lock that doesn't even let you open the thing for 2 minutes after it stops. which kind of undermines the whole point of quick microwave convenience. A better idea may be to just kind of child-proof the door, so you have to turn a knob while pressing a button to pop the door open. When people express concerns over microwave oven safety, though, they're probably not thinking about exploding eggs or hair wax injuries. They're concerned about the microwave radiation itself. Microwave oven manufacturers caution people not to operate the oven with the door open, but there are interlocking safety switches that should turn it off automatically when you open the door, unless you're stuck inside one. God, I couldn't even read that article. There is some leakage of microwave radiation, though, during operation. There's this famous radio telescope scanning the cosmos for extraterrestrial civilizations. Fast radio bursts were detected, a sign of extragalactic intelligence. Nope, turns out ET was a microwave in the staff cafeteria that the telescope caught when it was just at the right angle, right when someone yanked the door open. You don't need a radio telescope to see it, though. A cheap way of detecting microwave oven leakage is to just place a computer monitor next to the oven. You can see disturbances on the screen. Or just use the microwave detector you have in your pocket or purse right now. Cell phones. Look, if microwaves can leak out, then they should also be able to leak in. The microwaves are actually quite similar in size, the wavelengths, though obviously different intensity between microwave ovens and cell phones. So stick your phone in the microwave. Do not turn the microwave on, but close the door and see if you can call it. When you hear it ringing, that's confirmation that microwave-type radiation can leak in and out. And indeed, you can just directly measure the leakage during operation, though nearly all within prescribed safety limits. And once you move the detectors like a foot away from the door, the levels fall nearly to zero, even if there's some food particle or something caught in the door seal. Now, the industry will tell you that there has never been any verified case of human injury due to exposure from radiation leakage from microwave ovens. This is from a guy at Raytheon, though, where the microwave oven was invented, after an engineer in a radar lab noticed the chocolate bar in his pocket had melted. There has been the rare case report of a malfunctioning machine that didn't turn off when the door was open and someone burned themselves, but this was after her hand was in there for a full minute. Raytheon engineers talk about how they inadvertently expose themselves lots of times to open active microwaves. They get a warm tummy, they feel a little transient warmth when they pass their arm in and out of the oven, but no big deal, they say. In fact, the same microwaves used in microwave ovens are the same used for medical microwave diathermy, which physical therapists use like a hot pack to treat rotator cuff injuries. Now, making the claim that, well, if the medical profession uses it, it must be safe, isn't exactly the strongest argument, but does help to put things in perspective. When the heating of people is not deliberate, it may be desirable to limit exposure. Is that minor leakage during operation anything to worry about, though? In other words, are there non-thermal effects of microwaves? If it doesn't burn you, can it still hurt you? The Soviets thought so, irradiating everyone in the U.S. Embassy in Moscow for decades. In terms of microwave ovens, though, the only report I could find was from over 40 years ago, a case report of a woman who developed cataracts after using a leaky microwave oven. But that's all there was, just this kind of circumstantial evidence correlation. I mean, look, lots of people get cataracts, lots of people use microwaves. There has to be more than that. The only follow-up study I could find was this Turkish study, published a few decades later, but it was on rats. Now, they did end up finding some superficial eye abnormalities on the rats placed next to the microwave, but they were right up against the door, and people don't tend to stick their faces right up to the glass while things are cooking. So even if the same thing happened to human eyes, this study might be of limited relevance, but it can't hurt to stand back from the microwave while it's on. Otherwise, microwaves should be safe, unless you drop it on your foot.